I'm a general and upper GI surgeon in Southeast Wales, in Cardiff, with a particular interest in upper GI cancer. Enhanced recovery after surgery is very well established, but things are developing because I think there's a lot more to enhanced recovery than just the immediate 24 hours around the surgery and then the next 7 or 10 days. It's the whole process and program that starts once the patient is diagnosed with a condition that requires surgery, including pre-habilitation, enhanced recovery immediately, discharge, and then what happens afterwards. Lots of names on this slide, which emphasizes the size and multidisciplinary nature of the team that you require if you're going to deliver this sort of quite intense program. Now, I've used this slide for several talks, for general surgery, for cancer, and I think it just emphasizes the number of contemporary controversies that exist. Of several conditions, as surgeons, we can't agree on the optimum treatment at the moment, both nationally and internationally. We're still arguing about which surgeons should do certain procedures, which hospitals to do certain procedures. We're arguing about centralization, regionalization. We argue about how we stage cancer, about how we physiologically stage patients. Neoadjuvant treatment, we can't decide on the optimum form of that. We still debate which is the correct surgical approach, and now we're faced with the spectre of league tables, which have actually arrived, albeit in a very controversial form. Now, some of you may know that Professor Archie Cochrane practiced in Cardiff, and he was the inventor, in many ways, of the randomized controlled trial, and this is his seminal book here on the left, Effectiveness and Efficiency, whereby he emphasized that we've got a lot of treatments, but many of them are actually completely ineffective, but nevertheless very popular. Okay? This slide it shows all the normal confounding factors and things that we like to think form part of evidence-based practice and enhanced recovery after surgery. But it's quite a difficult concept to get across to managers and politicians to some degree. And this is a word that I think summarizes it well. Esemplastic. You've probably not heard that very often. It's from the Greek, eis en platon, having the ability to shape diverse elements or concepts into a unified whole. Now, managers don't get this. Politicians more frequently do. Okay? And it's difficult convincing people to throw resource and assets at this concept. So, where are the areas that have not received focus? And our guest speakers are going to, in turn, deal with these areas, I think, in their own way. Okay? It's not just about the perioperative time. It's about pre-habilitation. It's about education of the patient, about their fitness, nutrition, pre-mortem lifestyle. I'm going to touch on body composition analysis, which is becoming very interesting. It's about educating not only the patient, but their relatives. Clearly, anesthesia and surgery, very important. It's got to be meticulous, it's got to be goal-directed. You can aim to admit on the day of surgery, though it's seldom possible for the major cases. Fluid balance is very crucial and often far less than optimal. Okay? Pain management strategies, still controversial. And where we frequently get things wrong, we assume things are fine when they're discharged, but we really don't know what's going on in the community afterwards. Okay? Compliance. There's clearly a margin of influence depending on how much of the program you have in place the patient and the nursing staff and the doctors are compliant with. And finally, economic analysis, and I'll touch very briefly on that, which is not quite as simple as you think, because you need professional medical economics specialists to calculate that sort of thing. Okay? Now, NICE have guidance on economic assessments, and they have a threshold for a treatment to be worthwhile and cost-effective. To save a life, 1 year or 5 years must cost $30,000 or less. Sometimes they'll quote a number of £20,000. Okay. Now, how do they arrive at that? Well, here's what about £450 buys you in the contemporary NHS. A thousandth of a Challenger tank, which list price when I checked this morning was £4.217 million. Okay. Those are the other things that £450 currently buys you. And they more or less stay in balance as the years go by. Okay. Now, we've looked at our own enhanced recovery program in Southeast Wales that's serving the population of the whole M4 corridor in upper GI cancer. Very difficult to do a randomized control trial, but we've done the next best thing, which is a propensity score analysis of enhanced recovery programs. And we've got the ERP in yellow there. And after we introduced that approximately 4 years ago, we reduced our morbidity very slightly. Our mortality actually increased by 1%. Our length of stay in critical care remained the same, but our length of stay reduced by 3 days, which I think is in keeping with other studies, and that came out on multivariable analysis. But what isn't published, and where we're moving next, is what did that actually cost? And if we take out the most expensive item there, the most expensive disease we deal with, esophageal cancer treatment, when we figure in every little bit of the pathway, every blood test, every clinic appointment, to save a life at 1 year with esophageal cancer and surgery, it costs £8,000 compared with best supportive care. So that's well under the threshold. Interestingly, that's the same for definitive chemoradiotherapy, and it's the same for total gastrectomy. Okay? Finally, I'm going to touch on this. I don't know whether my co-speakers will get to this. This is now proving to be extremely interesting arena. Body composition analysis, or bioimpedance assessment. But as we can touch on that discussion at the end, it's clear that there's a lot going on that we do not understand. And when we've run these three things against malignant stage of disease, sarcopenia, that's your lean muscle mass, total body water, and phase angle, they knock stage of disease totally out of any multivariable analysis. The problem with this is there are several confounding factors. It depends what time of the day you measure it. It depends when the patient last had a cup of tea or a cup of coffee. And it varies according to the time of the day. So there's a lot going on, and there's a lot of research that needs to be done. Okay? So I'm going to hand over now to John Mcphee to introduce the next speaker. Thank you very much.
Thank you very much. Thank you, John, for the very kind introduction. It's a pleasure to be here, and I'm grateful for the invitation to an anaesthetist and intensivist to this great surgical meeting. I'm going to, if you forgive the pun, jog through a few slides on prehabilitation and new concepts in prehabilitation. I'm going to start by saying a few words about the relationship between lifestyle factors and health in general. Talk a little bit about some general comments about preparing patients for surgery, and then focus on individual elements of prehabilitation, and then at the end come back to the idea of how we prepare patients for surgery and the implications for this new information we have about prehabilitation for the preoperative pathway. So this is a fantastic paper. I don't know if many of you have seen it. It was published in The Lancet last year, and it's an epidemiological overview of the determinants of health and disease in the United Kingdom over the 23 years from 1990 to 2013. So it's a great sweeping piece of work. And amongst the good news in it, life expectancy has increased by between 5 and 6 years during that period of time. So over only 23 years, life expectancy has gone up by 5 years. The interesting information that it gives us in relation to this talk is some general analysis of the factors that determine health and disease. And if you look at this pie chart here, you can see in blue purely behavioural factors, in purple behavioural and metabolic factors, and in green behavioural and environmental factors. And you can see that behavioural factors contribute between 2/3 and 3/4 of the entire burden of disease in the United Kingdom based on this epidemiological analysis. Now that may seem like a very strong statement, but if we simplify that a bit and explore its face validity, if you think about how you feel on the morning of New Year's Day on the 1st of January, after what's gone before, and then how you feel on the morning of the 1st of February after a month of austerity and good behaviour, and that it is somewhat credible that behavioural factors could have a substantial impact on health in general, and indeed the areas of health we're concerned with around the time of surgery. So these are, as I've seen written down in a few places now, 5 driving principles of enhanced recovery from a patient perspective. So the first one is that the patient is a partner in their own care, and then they follow through the patient journey and focus on making the right decision, ensuring the patient is adequately prepared for surgery, that they're cared for during surgery, and that they recover well. And the focus today is on this element, so making sure that they are prepared for surgery in order that they will be resilient to the stresses and strains that we as anaesthetists and surgeons put them through. So if we think of a standard model of what determines preoperative risk, there are some fixed factors and there are some modifiable factors. Some things are entirely innate, there's nothing we can do about them: age, gender, your genetics, for example. And some are to a degree modifiable, but actually relatively fixed. And there are others, like the lifestyle factors, where we can have a substantial impact. And there's a spectrum of activity working with patients, where we can look at, on one end of the spectrum, collaborative decision-making, and on the other end of the spectrum, collaborative behavioural change. So if we focus on the innate and acquired factors, I think we're all becoming accustomed with the concept of collaborative decision-making, the avoidance of so-called wrong patient surgery, patients who actually, with a full understanding of harms and benefits, would have chosen not to go ahead with the procedure, and the knock-on effect of the fact that many of those patients are those at the highest risk, therefore likely to have complications, and therefore, overall, this is likely to reduce post-operative harm. There's a considerable emphasis at the moment on some of the acquired factors, so there's an increasing number of preoperative clinics focusing on anemia, diabetes, heart failure, and even more recently I've seen a couple of clinics focusing specifically on implantable cardiac devices and preparation for surgery for patients with those in place. And that's an important element. But the focus this afternoon is on the lifestyle factors and what, if anything, we can do about those, because they ought to be modifiable, and one would hope that through modifying them one could improve patient outcome. So we have this concept of pre-habilitation. So any process that enhances the functional capacity of a patient or an individual to deal with a particular stressor. So in layman's terms, this is all about resilience, giving them the physiological reserve and perhaps psychological reserve to cope with the stresses and strains of surgery. And I think one can make a case that we have a particular, possibly unique opportunity before surgery where patients are faced with a very specific time point where they're going to be at substantial risk, and there's a very high degree of motivation to alter some of these lifestyle factors, so alter behaviour, in such a way that actually not only may it be a benefit to them in relation to that surgery, but there may be knock-on effects in terms of sustained behavioural change over the life course that could impact long-term survival. So the key areas that are typically looked at include alcohol, smoking, diet and obesity, activity and exercise, and increasingly psychological preparation for surgery. I'm going to run through the literature supporting each of these relatively quickly. The headline, if you like, is that there is remarkably little data for what, on the face of it, are very obvious interventions before surgery. So you would imagine that quite a large number of patients would have been studied in relation to alcohol cessation before surgery, and in fact, in the most recent Cochrane review, which is only last year, there are less than 100 patients in randomized trials of alcohol cessation before surgery. Having said that, despite the small numbers, there looks like there's a treatment effect, so a reduction in complications. Clearly, this needs validation in larger studies, but to me, the most striking thing is not the treatment effect, but the fact that we, as a community, have studied so few patients. There's possibly an impact on length of stay. There's no impact on mortality, but that shouldn't surprise us at all. There's so few patients here that you wouldn't expect to see any impact on mortality. And so these are the author's conclusions. Significant reduction of post-operative complications, but an extraordinary small literature. If we look at smoking cessation, it's not quite as bad, but it's similar. Only just over 1,000 patients randomized into studies of smoking cessation before surgery. They fall into 2 families. I've highlighted in red the intensive smoking cessation studies, including just over 200 patients. They show benefit in contrast to the general provision of advice and a bit of encouragement, which seems to make no difference at all. So smoking cessation is effective at reducing smoking both at time of surgery and consistent with what I was suggesting in terms of sustained behavioural change 12 months after surgery. So if you have an intervention in the period before surgery, there's a sustained behavioural change. And it looks like it reduces complications in the intensive group, but not in the simple advice and encouragement group. So authors' conclusions. But again, a huge hole in the literature from my perspective. It is extraordinary that we have so little data. In terms of dietary modification, the next speaker I think is going to touch on this, the next but one speaker is going to touch on this in considerably more detail, but if you're looking for pointers for general nutritional support for patients before surgery, there's remarkably little data. These were the two systematic reviews that I could find, not for patients who are nutritionally challenged, but for nutritional advice in general. Very few studies, no obvious evidence of benefit. There is a very recent study, so this is published a couple of weeks ago from Frank O'Carley's group in Canada, which shows quite an extraordinary result in a small study. So 43 patients given a whey protein supplement during the preoperative period, patients undergoing elective colorectal surgery, that show an increase in physical fitness measured using a 6-minute walking test, simply through a nutritional intervention, the provision of whey protein. So surprising and provocative, but a relatively small study. And then the psychological preparation, and our orthopaedic colleagues have been doing this substantially longer than us. So the idea of joint school, I highlight here the one we have in Southampton, but the idea of joint school has been around for a while, and patients, and it's all obviously this is all about the expectation management elements of enhanced recovery. But it's important to think about if we, as I will in a moment, start to think about how we modify the structure of the preoperative pathway. And there are now, in a number of centres around the country, surgery schools or fit for surgery schools for a much broader spectrum of surgical procedures. So the remainder of the discussion about pre-habilitation specifically, I'll focus on exercise and activity. And again, there's not a lot of data. So this is a systematic review we did 3 years ago now, identifying only 10 studies and just over 500 patients in patients having intracavity surgery. So this includes intra-abdominal, but also intrathoracic and cardiac surgery. And the only study that showed an outcome benefit is a cardiac surgical study from about 15 years ago now, which showed a reduction in length of stay with an exercise intervention. Now, we, in our group, had looked at doing these sort of exercise studies about 15 years ago in elective gastrointestinal cancer surgery, and we'd actually given up on the idea because we couldn't get a window of opportunity between referral and diagnosis and surgery because the pressure at the time on the waiting lists had meant that there simply wasn't the space. Patients were coming rapidly to operation. What changed in the intervening period was the introduction of neoadjuvant chemotherapy, which extended the time from diagnosis to surgery and introduced both a period of time for chemotherapy, but also a period of time for recovery. And I guess that should give us a little bit of a clue because there's an implicit recognition there that the chemotherapy might be doing something that could have a harmful impact on surgery, otherwise you wouldn't need a period of recovery. So we started looking in late 2000s at the impact of neoadjuvant chemotherapy on patients undergoing surgery. This is patients undergoing upper GI cancer surgery, working with collaborators at Aintree. And there's a consistent and statistically significant reduction in exercise capacity. This is measured using cardiopulmonary exercise testing, and it's the oxygen consumption at anaerobic threshold. So there's a consistent reduction in exercise capacity from before to after neoadjuvant chemotherapy. That was associated with mortality. This is slightly complex data to interpret, but data from more recent study we've got shows that there is, this is in about 150 patients, that the magnitude of fall in physical fitness associated with the chemotherapy is related to the likelihood of having subsequent complications and mortality. What's more, unfortunately, there's absolutely no relationship between the positive benefits in the chemotherapy in terms of tumour regression and the adverse effects of chemotherapy in terms of the fall in physical fitness. So you can see here, it's a slightly complex slide, but in blue you've got no change. Red is a tumour that's upstaging despite chemotherapy. Green is a tumour that's downstaging, as one would hope with chemotherapy, and the gradient of the line represents the change in physical fitness. So there are patients whose tumour is upstaging, who are also losing physical fitness, who've had absolutely no benefit and arguably a substantial harm from their chemotherapy, whereas there are others that have had a minimal hit on their physical fitness and the tumours significantly downstage. So clearly an area where personalised medicine in the future may be of great benefit if we can select out the different effects both on fitness and the tumour. We then looked in lower GI surgery, and you can see a similar fall, clinically significant fall in oxygen consumption at the anaerobic threshold, again measured cardiopulmonary exercise testing with neoadjuvant chemoradiotherapy before lower GI surgery. And the obvious thing to follow on from that was, can we train these people up? Can we train these patients such that we can get back that loss in physical fitness that's been caused by the chemotherapy? This is the results of our initial non-randomized study. So a convenience allocation based on logistics, basically. The patients in the control group are those who lived a long way from the hospital or had carer duties for their nearest and dearest. The patients in the intervention group are those that could come and take part in an exercise study. And you can see the 3 time points from before to after chemotherapy, so the same fall, significant fall in physical fitness with chemotherapy. In the continuous line, that fall continues downwards, and in the dashed line, which is the trained group, their physical fitness bounces back at least to baseline, if not beyond. And the 2 variables are the oxygen consumption at anaerobic threshold and peak oxygen consumption. We're close to the end of the randomized control trial that's followed this. Obviously, I can't share the results of that with you at the moment. But if you look out to the full 14 weeks when these patients were operated, you can see a sustained and actually growing difference in physical fitness by the time they get to their time of surgery that we don't know for sure impacts outcome, but if the relationship between physical fitness and outcome that we know from a whole host of other studies is maintained, then it's highly likely to impact outcome. This is another study from the Carley group looking at pre-habilitation and post-habilitation. Just to emphasize, it's not pre-habilitation versus post-habilitation. One group start with pre-habilitation and continue the intervention in the post-operative period. The second group start in the post-operative period. And I guess not terribly surprisingly, and this is also a multimodal intervention, so it's exercise, diet, and a psychological support intervention. But not surprisingly, if you start before surgery and then you continue after surgery, you get a better impact on physical fitness, in this case 6-minute walk test, than if you only start after surgery. It doesn't answer the question as to which gives you the most benefit, the before or after, if you're in a situation of only being able to afford one. Why does it work? Well, I don't think it works because it's all about hearts and lungs. I think it's probably something far more fundamental and relates to metabolism. And this is functional MRI data looking at phosphocreatine time constants. You can see change in phosphocreatine time constants on the left-hand side as you look at it, and the fall in VO2 peak and VO2 lactate threshold in a number of patients, and you can see that they're relatively closely correlated, and this is from before chemotherapy to after chemotherapy. If you then train them, in the control group, you see no change in either variable. In the exercise group, their mitochondrial physiology improves consistent with the way that their measured whole body cardiopulmonary exercise testing physiology improves. And we're starting to see this data in others of the training studies we're doing. So I think this may be a much more complex story about metabolism, the ability to withstand oxidative stress, and that kind of thing, rather than a simple heart-lung physiology story. I show you this data with some reticence, but it is provocative. When we started looking at this intervention, we were slightly concerned that if we were going to improve muscle physiology through exercise training, and therefore muscle resilience to chemotherapy, there might be a harmful effect that meant we also improve tumour resilience to chemotherapy. So it might actually be a cause of more tumour progression. In fact, in the very limited data we've got, it appears to be the other way around. So the patients who get the greatest response to their training intervention also seem to get the greatest reduction in tumour size using magnetic resonance tumour grading scores. It's very early data. We're tracking this again in the randomised study that we're doing, so we'll see if the same data comes through. But very provocative, it's true, and kind of consistent with all the other data that we know about the relationship between physical fitness and activity and survival in cancer, both in newly diagnosed cancer patients and in cancer patients during and after treatment. There are a number of other studies going on. These are the ones from our group, so we're now starting to look at training during chemotherapy, before and after surgery, and in chemotherapy not related to surgery. So we've got a study going at the moment in palliative lung cancer surgery. There are some interesting studies around using the high-intensity approach. So some of you may have seen on television this very short, sharp, work as hard as you can for 30 seconds for a minute, a few times in a row, and that's as good as doing half an hour or an hour of exercise. And this study is now completed. It's a high-intensity study in aortic aneurysm, elective aortic aneurysm surgery, and this will be reporting during 2016. And there's some interesting behavioural change studies coming along. So big HTA grant approved last year, looking at a major programme evaluating smoking cessation in much more detail before surgery. There are a lot of challenges. These studies, to show benefit, will need big studies. The outcomes of interest, because outcomes within enhanced recovery are generally good, therefore adverse outcomes are relatively rare. The sample sizes have to be high. In order to get high sample sizes, you need to have multiple types of surgery, and in order to do that, you end up with a heterogeneous population. So the studies will be challenging. I think the efficacy data will come. There are more than 30 studies currently on clinicaltrials.gov in this area, but they're all relatively small efficacy studies. The effectiveness studies will be challenging. I don't suppose anybody recognises this tube map. So it's my schematic of the perioperative journey as it may be in the future, with various challenges along the way and various opportunities to intervene and improve along the way. And you can see that if you start with a survival threshold which says that you're a relatively fit individual, you've got lots of reserve, then you're probably going to be fine almost whatever we do. But if your survival threshold relates to less physiological reserve, without these interventions along the journey, you may not get through this path. Now, the obvious thing that stems from what I've just talked about is that it's not really consistent with a lot of our current pathway. Typically, and I don't know if your hospital is similar to ours, but typically a lot of the assessment relating to these kind of issues happens late in the journey. The pre-assessment clinic happens somewhere between 1 day and 1 week before surgery, and the opportunity to intervene is often missed. What we do have the opportunity to do is potentially change that pathway completely by moving the opportunity to intervene right back to the beginning, right back to the moment of contemplation of surgery. So actually start to, as GPs refer through to the surgical clinics, start to collect data on who's likely to be high risk, who's likely to benefit from dietary modification, smoking cessation, alcohol cessation, or physical fitness interventions, and give us the time to intervene before surgery. So to conclude, there is ample evidence, I've given you some from the United Kingdom context, but there's ample evidence that lifestyle factors are really key determinants of health and disease. There are a number of opportunities that present themselves in terms of lifestyle modification, particularly alcohol, smoking, the diet obesity piece, and activity exercise. But there are questions as to the effectiveness of this when implemented at scale. There's lots of feasibility and efficacy work going on at the moment in exercise training, but the effectiveness studies will be challenging. There's some interesting work progressing with alcohol cessation, and I suspect we'll see similar in smoking and dietary modification soon, and then the obvious sort of combination multimodal approaches. But I think this will end up leading to us having to redesign the preoperative pathway to a degree to make sure that we make space to improve health through these types of interventions before surgery. Thank you very much for listening.
So, first of all, could I thank the organisers for this symposium for inviting me to speak today. And this afternoon I'm going to share some work that I've been undertaking on preoperative nutrition, concentrating predominantly on undernutrition, because that's the area I've done quite a bit of work in and particularly interested in with regard to nutritional assessment and then what we actually do when we define or identify poor nutritional status. So first of all, I always start presentations with a definition, and this is just really to refresh your memory, really, and remind people what we actually mean when we talk about undernutrition. When I talk about undernutrition, I'm talking about people with a low BMI, less than 18.5, unintentional weight loss, greater than 10%, or a combination of unintentional weight loss and a low BMI, or people who haven't actually eaten for the previous 5 days. So with regard to preoperative nutrition, it's an area I've always been quite passionate about, because as a dietitian, we used to treat a lot of people who came into hospital who were undernourished, and I often thought this was something we probably needed to address way down the line in clinical outpatients and also in pre-op assessment clinics. So nationally, we're very good at doing the malnutrition universal screening tool, and it's implemented really well in most hospitals in the UK. And this will identify patients who are malnourished, at risk of malnutrition, and also patients who are overweight or obese. So we're good at screening patients on admission, although once patients are actually in outpatients, in surgical outpatients or most outpatient departments, we don't actually assess nutritional status very well. BMI, as I'll go on to show, isn't really telling us a lot about the nutritional status of patients pre-op. So there is the opportunity to do MUST at pre-op clinics, and I know in some hospitals it can be added on to the ERAS pathway, so nutritional status is done at pre-op, and the patients can be referred to dietitians if they are malnourished or at risk of malnutrition, even before they come in for surgery, to tighten up the pathway and identify these people. So introducing this tool as an enhancement of ERAS is probably something that's worth doing. Also, nationally, we have self-screening in relation to patients being able to assess nutritional status, and the British Association of Prenatal Nutrition have a tool where patients can do self-assessment, and this provides us with a really good opportunity to start looking at mega online open access courses to inform people and start giving people information about overnutrition, but also about undernutrition and strategies to attack this or deal with this for their own care. So patients who are admitted to surgical wards, this was data on 35,000 patients, which was recorded during the nutritional screening week, that does actually show 1 in 4 patients admitted to surgical wards are at risk of malnutrition or are malnourished on admission to hospital. And surgical wards are somewhere in the middle of that chart. So this slide shows quite well that if we're actually looking at nutritional status, just looking at body mass index is going to give you a false picture of what's happening in relation to nutritional status. Here there's a direct crossover between patients who've had more than 10% of their body weight loss and patients who are actually overweight. So you need a combination of a tool that's looking at percentage weight loss with height and weight. And something on oral intake, not just body mass index. So other forms of nutritional assessment that are actually available to us are things like subjective global assessment that incorporate percentage weight loss, clinical condition, and visual assessment of muscle loss, and patient-generated subjective global assessment that patients can do independently. There's biomarkers, but predominantly biomarkers within nutrition probably are only relevant for looking at single nutrients or some protein biomarkers with prealbumin and transferrin and hematinics. But recently in the Lancet, there was some comments that hand grip strength was the new biomarker for older people, and there was quite a strong correlation between decreased function, morbidity and mortality in patients who had a low hand grip strength from an epidemiological study, and it was named the new biomarker in nutrition. We still have the traditional skin fold thicknesses, looking at mid-upper arm circumference and tricep skin fold thicknesses. Bioelectrical impedance monitoring that is becoming more important in nutritional assessment in hospitals. MRI scans, which we can calculate body mass composition from, looking at fat-free mass and fat mass. CT scans, and also our team's looking at whether or not we can actually use ultrasound in clinical trials to measure body composition and skeletal muscle mass. So sarcopenia you've heard about already, which is becoming increasingly interesting in nutrition. And here we can see why, because it's giving us more information and turning the tables around a little bit, because here you have somebody with a BMI of 27, a small amount of weight loss, who is actually sarcopenic. The brown area is the muscle area. Although you have somebody with a BMI who's 22, lost more than 10% of their body weight, but does have a muscle area that's fine, that's within the normal reference ranges. And the reference ranges we tend to use for sarcopenia is 2 standard deviations from that of the normal population based on the NHANES data. So it's not always practical to look at doing CT scans or looking at nutritional status from CT scans. So as a dietitian, I was very interested in looking at other ways we can actually measure sarcopenia in patients preoperatively. And this was some results taken from a study where we looked at 100 patients preoperatively with colorectal cancer who had lost weight. And we did the CT scans that we used as our criteria measure, bioelectrical impedance monitoring, mid-arm muscle circumference, and patient-generated subjective global assessment. And as you can see, if we're looking at the identification of low muscle mass compared to CT scans, bioelectrical impedance and mid-arm muscle circumference come out okay in relation to level of agreement. When we look at sarcopenia, where we're using low muscle mass combined with a physical measurement, and here we used hand grip strength to determine functionality, we can also see good level of agreement with bioelectrical impedance monitoring and mid-upper arm circumference. And then moving on to patients who were cachectic, we also saw a good level of agreement, but we didn't have many patients who were cachectic in the sense that they had a low skeletal muscle mass, they had low function, and also had an elevated CRP in our population. So we didn't have many patients that we found. We found that in the pre-op population with colorectal cancer patients, 29% of our participants had low skeletal muscle mass when we looked at that with CT scans. And in relation to sarcopenia, 14% of the population had sarcopenia with a low skeletal muscle mass and low physical function measured by hand grip strength. So this talks a little bit or moves on now to, well, if we identify undernutrition preoperatively, if we incorporate nutritional assessment and screening preoperatively with surgical patients, can we actually do anything about it, and what's the literature actually saying? So this was a Cochrane we undertook looking at preoperative nutritional support in patients undergoing gastrointestinal surgery. And we had to include immune-enhancing nutrition in this review, and we found from 6 studies giving patient immune-enhancing nutrition, which was enriched with omega-3, arginine, and increased antioxidants, did actually show an improvement on total complications when combined. And these are just the studies where we could extract the data, which is just pre-op data. So we needed the measurement prior to surgery and excluded data where it was combined perioperative immune-enhancing nutrition. So there is some evidence that preoperatively immune-enhancing nutrition is beneficial, but the studies were all done prior to ERAS initiation. They excluded patients on neoadjuvant chemo or those having radiotherapy, so higher grade tumours, and also excluded most people with multiple morbidity. So we included studies on parental nutrition because we did go back, and there was 3 studies very early on, or quite old now, which looked at preoperative parental nutrition. And this shows that when we do feed patients, we do have an impact on total complications post-surgery. However, this slide is subject to quite a lot of temporal bias because this actually included all comers coming to surgery who were malnourished, and in today's practice we wouldn't do that in relation to parental nutrition feeding. So looking at standard oral nutritional supplements compared to no nutritional supplements, and looking at the effect on total complications. And there was 3 studies at the point I did this Cochrane review that looked at preoperatively identifying all comers, randomizing them, and just giving people preoperative oral supplements didn't make any difference. Other studies were quite mixed, 2 against, 1 for. The study that was undertaken that looked at preoperative oral nutritional supplements that didn't show any benefit on post-operative complications was an RCT. One of them was one I did. And we randomized patients. The control received dietary advice. The intervention group received oral supplementation pre-operatively. However, we found no difference. The difference was identified on subgroup analysis with patients who were weight losing. So we used that in relation to hypothesis generating to design our next study. So this was a single-blind randomized controlled trial of preoperative oral supplements in weight-losing colorectal cancer patients. It was a single-blind trial designed to determine effectiveness, and the intervention was preoperative oral nutritional supplements. The control received dietary advice, and the intervention was oral SIP feeds, and the dietary advice. So that was the nutritional composition of them. They received 2 125 ml cartons, and the patients were recruited at the point the surgeon placed them on the list for the theatre. So we had, with colorectal cancer patients, a wide range of number of days prior to surgery. But to be enrolled in this trial, patients had to be able to have the SIP feeds up to the point of the carbohydrate loading drinks the day before surgery. The controls received the same quantity or same volume of bottled water in a cardboard box. The boxes were labelled, so the researchers were blinded, but the patients weren't. We powered it on post-operative complications defined by the Centres for Disease Control. We required 88 patients in total, 44 in each arm. We used block randomization and stratified patients according to laparoscopic or open surgery or colon or rectal tumours. We included patients who had lost more than 1 kg. They had to have the SIP feeds, as I've said, for a minimum 5 days before surgery. They were all weight losing, and the colorectal surgery was planned to be curative. Primary tumour, informed consent. Our primary outcome was post-operative chest and surgical site infections. Secondary outcomes were total complications, nutritional status and body composition. And we saw patients at baseline with a minimum of 5 days prior to surgery that we could actually give the patients the oral SIP feeds. We saw them 24 to 48 hours pre-operatively and then 5 to 7 days post-operatively. And we recorded outcomes up to 30 days post-op. So this was the consort diagram we actually completed. So we performed an intent to treat analysis. One patient withdrew consent early on. So although we recruited 46 in the control, we've only analysed 44 and used his data up to the point he withdrew consent. And what we found on intent to treat analysis, that if we identified patients as weight losing preoperatively, we had a significant effect on surgical site infections post-operatively. On intent to treat and per protocol analysis, where we looked at patients who'd managed more than 25% of the oral supplements, we had a significant on patients with one or more surgical site infections or chest infections, and again on the surgical site infections. Now, the trial tells a nice story because we significantly increased calories and protein preoperatively from baseline to the pre-op visit in the patients given the supplements. So basically, the patients took them and it did their job. We increased the nutritional intake of the patients who were given the oral supplements. With regard to secondary outcomes, we were interested in looking at nutritional parameters, and we looked at percentage weight loss at each point. And patients 24 to 48 hours preoperatively had a lower percentage weight loss that was significant in the group that had the oral nutritional supplements, and this was actually maintained 5 to 7 days post-operatively as well. So by improving nutrition of patients preoperatively, we demonstrated that we increased energy and protein, which subsequently minimized the amount of weight they lost. We looked at body composition with this cohort, and we looked at the difference between pre-op baseline and pre-op. And with body composition, when we're looking at measuring fat-free mass or skeletal muscle mass, to make it pertinent to individuals, we actually divide it by height squared to give fat-free mass index. And the difference in fat-free mass index measured with bioelectrical impedance monitoring actually demonstrated with our patients that when they actually lost weight, they were losing muscle. So if the patients were sarcopenic preoperatively, giving them oral nutritional supplements did actually mean they lost less weight over the perioperative course and lost less muscle. We didn't see a difference in fat. So to conclude what I've been talking about, preoperative oral nutritional supplements reduce surgical site infections in people with colorectal cancer. Chest and surgical site infections decrease when people manage more than 25% of the oral supplements. Participants on the preoperative oral nutritional supplements lost less percentage weight loss, and this was maintained post-operatively, and when they lost weight, they lost skeletal muscle mass. So the take-home messages from my presentation is nutritional screening in pre-op clinics in surgical outpatients is essential, and the Malnutrition Universal Screening Tool does actually serve that purpose of assessing nutritional status, incorporating percentage weight loss and body mass index to actually all start talking about the same thing. It does identify patients who are overweight and also obese. Preoperative nutritional status influences post-operative outcome. I don't think we can argue with that given the strength in the literature. Sarcopenia, or low skeletal muscle mass, is becoming increasingly important as a prognostic variable preoperatively. And over the next few years, it's going to be interesting how we actually incorporate clinical measurements to start actually being able to say if patients are sarcopenic or not from a dietetic perspective. Once weight loss or undernutrition is identified, we can actually do something about it. And the trial I did does actually say or show that patients increased the nutritional intake with oral nutritional supplements compared to dietary advice. The oral nutritional supplements did their job. It minimized weight loss and minimized skeletal muscle mass loss, as well as affecting post-operative outcome. So research is never done as an individual, so I'd just like to acknowledge the main people that have been on a journey with me whilst I've been doing some of the research I presented today, and acknowledge the other members of the team with the research that's been undertaken. So thank you.
Good afternoon, everybody. Thank you to the chairman, and thank you for the organising committee for inviting me to present our results of our feasibility study, entitled Fit for List, Optimising the Health Status of Patients with Suspected Cancer in Primary Care, Is It Feasible? Our population in Wales is vulnerable from a health status point of view. We have poor general health, increasing age and deprivation when compared to England. 20% of our population smoke, 40% drink more than the alcohol recommendations, 34% take no regular exercise, and as a result, 58% of our population are overweight. This manifests in numerous comorbidities listed here on the slide. An audit published in 2011 by the Royal College of General Practitioners looked at all urgent suspected cancer referrals, and the aim was to obviously look at what was happening in primary care in terms of patients being referred on urgent suspected cancer pathways. One of the interesting secondary findings was that the patients are obviously presenting with numerous other comorbidities, such as fatigue, anemia, weight loss, breathlessness, nausea, vomiting. And also, what was interesting is often these were failure to be corrected. Failure to correct these issues in primary care can then subsequently result in poorer clinical outcome for patients. We've heard from Professor Grocott extensively in his talk on Pre-habilitation, so I'm not going to go into any detail, but effectively we know that social economic status, health literacy impact on cancer outcomes. And again, we've heard that many of these are modifiable in terms of smoking, alcohol, obesity, comorbidities, and anemia and poor nutrition. When we looked at our cancellation rates in Wales, which was incredibly hard to find, we know that around 70,000 operations in Wales alone are cancelled per annum. Looking into this literature in more detail, we know that 10 to 20% of our surgical procedures are cancelled for medical reasons or the patient's unfit on the day of surgery. That is no less than 25 patients per health board per week. When you look at chemotherapy, again, this is an American stat, because again, it was very hard to find the local stat, but we know from America that about 25% of patients undergoing chemotherapy have their chemotherapy delayed because of medical reasons. Again, taking on board what Professor Grocott said, looking at the analogy with sport. I'm sure you all know this is marathon dressage. Individuals compete over 6 days, grueling temperatures, and the success to finishing and completing this marathon is peak mental condition, good nutrition, and exercise, obviously training. And this is our marathon to cancer. About 350,000 people undergo this marathon in the UK each annum. So can we learn from sport? The theory of marginal gains is often taken on by the British cycling team, looking at all the little things that actually contribute to overall gain for that team. Looking at what they wear, even simple things like washing their hands have been taken to show that it actually impacts on outcome. So can we learn from this for our cancer patients? This is the concept that's obviously behind enhanced recovery. And you can see this is our enhanced recovery programme in Wales, very similar to the English programme, based on 5 care pathways. You can see prehabilitation is obviously highlighted here in red. And initially, the concept was discussed in Welsh Government and the directors of primary care about whether we could actually use the concept of primary care optimisation. And the decision was made, obviously, to then go down the research route, which is what this research is going to share with you in a moment. So cancer prehabilitation is defined as a process on the cancer continuum from the time of cancer diagnosis to that of the beginning of acute treatment. The argument really is, prehabilitation, how long do you need to actually optimise patients' care? And Professor Grocott and his team have actually got a paper in press at the moment, which indicates that more research is needed as to understand how long we actually need to optimise our patients for maximum benefit. So in Wales, and certainly in Cardiff where this research is based, we asked the question, can this happen in primary care when the patient first presents and enters the healthcare system? The study is called Fit for List. It's been funded by the Wales School of Primary Care, and we started data collection in January 2015. The aim was to develop and pilot a Fit for List optimisation care bundle that would detect potential risk factors in primary care, enable subsequent timely intervention, and result in potentially improved preparation of patients who may undergo surgical or oncological treatment. This was a mixed method feasibility study. We looked at patients who presented to their GP in one of our recruited GP practices. All patients must have been referred by the GP using the urgent suspected cancer pathway. This is our flow through, so you can see in no patient care pathway was the treatment delayed. The referral was made, and obviously this was an adjunct to that referral in. This is a copy of our bundle, and I've actually printed out, so the bundle components include review and optimisation of existing comorbidities, and we use the existing GP registers to pull that information from the existing registries. Very simple. Is your patient anemic? Does your patient smoke? Does your patient drink alcohol within the recommendation? Does your patient have high blood pressure? Has AF? Raised blood glucose? HbA1c? And nutrition and exercise. We also developed a template for use by all GPs, which was actually loaded onto the GP system at the start of the study. And this really helped, along with education and training of GPs and practice nurses. So our results. We approached 195 patients. We consented 189 patients. And 189 patients were exposed to the bundle within primary care at their first initial consultation, or soon thereafter. We had 16 confirmed cases of cancer within secondary care. 26 patients did not present to the secondary care organisation, and 153 were subsequently deemed to have not a cancer. The median age was 60, which is obviously not surprising, and we had twice as many females presenting as we did males. The uptake of the bundle, so testing the concept of whether it's feasible, we had 189 patients who were exposed to elements of the bundle. 84 patients, so 44% of the whole study population, required some form of optimisation using the bundle. 63% of the cancer patients and 43% of the non-cancer patients. These are the reasons for the uptake of the bundle, and you can see that exercise advice was, and along with hypertension review, were the two top need an action within primary care. These are the types of suspected cancers referred in from primary care, and I'll just allow you to glance through the slide. We looked at the number of patients presenting with comorbidity, and around 65% of patients who were subsequently diagnosed with cancer had some degree of comorbidity at presentation. This slide indicates the varied nature of that comorbidity at that initial presentation. Hypertension. 44% of our confirmed cancer cases were hypertensive. 29, so 2 of those 7 were then subsequently deemed non-control, so had poor control with their hypertension and subsequently underwent a review of medication. 4 patients in the non-cancer group were considered to be and diagnosed with hypertension at that initial consultation. When we look at diabetes and hyperglycemia, you can see that 38% of the cancer patients were known diabetic, as opposed to 13% of the non-cancer patients. What's interesting here is the known patients with cancer, 66% of them had poor glycemic control indicated by a raised HbA1c. The ones who were not diabetic subsequently, 31% had raised HbA1c. Anemia. GPs were asked to do a full blood count screen at the initial consultation. 19% of the cancer patients had a history of anemia, and you can see that 18%, so 3 patients in the cancer group, were identified with newly detected anemia. All of these were started on iron therapy at that initial consultation. When we looked at smoking versus non-smokers, you can see 38% of our cancer population were currently smoking, and 32% of our non-cancer population were smoking. What's interesting is 3 of the current cancer smokers were actually referred for smoking cessation advice. 3 declined, and all of these smoked more than 20 cigarettes a day. Alcohol. Our cancer population, 25% were teetotal, as opposed to 30% in the non-cancer group. Again, if the individuals were deemed to have a high alcohol intake, the requirement was to start vitamin and mineral therapy. Exercise. 50% of the cancer group were inactive, as opposed to 25% of the non-cancer patients. The majority of the whole sample were not performing the recommendation of 120 minutes exercise per week. Nutrition. The majority of our cancer patients were either overweight or obese. Linking in with Sorrel's presentation, we know that a lot of these patients were actually weight losing. Again, linking in with sarcopenia. When we asked primary care of their views around the concept of using primary care as an optimisation of potential cancer treatment, this is the feedback we got from 2 individuals. What do you like about the concepts behind Fit for List research study? It's very sensible. So often they, patients, get to a preoperative assessment and stall due to a raised blood pressure, and then they are referred back to us. Or they're a higher anaesthetic risk than they need to be, or their recovery is not optimised. Do you think it benefits your patients, and if so, why? Yes, I believe so. Patients benefit as we give them advice, we optimising their health status, whether or not surgery is required or not. Often, they are very receptive at this vulnerable stage. And Dr. Crouch from Barry, this is something that should be routinely done for all patients. So to summarise, this feasibility study has concluded that pre-treatment optimisation in primary care is feasible. 44% of our overall study population required some form of optimisation at that initial consultation. This was subsequently followed up by practice nurse involvement. The reasons for this optimisation were smoking, exercise, hypertension management, and diabetes. Anemia was detected, not surprisingly, in 12% of all patients. Nutrition, Weight loss was occurring in 56% of the cancer patients and 14% of the non-cancer patients. We had a high incidence of obesity and overweight patients, which again is not surprising. And the majority of these patients were not exercising enough. Clearly, there are numerous limitations on this small-scale study. It's designed to be a proof of concept, test in the water whether we can engage with our primary care colleagues in this pathway. Compliance to the interventions was not assessed. Subsequently, clinical outcomes have not been assessed, and GPs were incentivised to take part in this research study. So to conclude, GPs and practice nurses have a major role to play in pre-cancer treatment optimisation. It is feasible and practical to manage the optimisation in primary care as an adjunct to the investigation and diagnostic process. Next steps, we are planning a large-scale randomised control trial to develop a step wedge cluster trial across Wales and certain centres in England. Just like to end on a quote. This is from the City of Hope in LA. There is no profit in curing the body if in the process we destroy the soul. And again, I'd like to acknowledge the patients who consented to take part in this research study and all the GPs and their practices that kindly assisted us with this study. Thank you very much.